So I'd like to introduce Sal Buffo. He is one of our counseling and guidance instructors, psychology, human development instructors, and he will now speak to the issues of the psychological implications of the First World War. So Sal, thank you very much for finishing up our lecture series today.
Thank you, Amy. I have to say, Matt, I have to have a confession. When you were giving your presentation, I sneezed, and I feel so guilty about that now. I don't think I'll ever sneeze again now. Exactly. Okay. Thank you all for coming. Much of what we have learned about psychological trauma has come from a lot of direct observations from returning soldiers that have been back from combat. And we observed their symptoms, and we've noted them. And we're beginning to understand even more now the relationship between the mind and the body. Yet we do know that the mind can affect our physical body in ways that sometimes we never thought possible. My hope today is to share how historically we have come to have a better understanding of this thing that we call trauma, and how treatment of this disorder has changed throughout the years. But before I begin, I'd like to pull out of my pocket a disclaimer. You know, every good teacher has a pocket full of disclaimers, just in case. And my disclaimer today is, I'm not a historian. I'm a psychologist. I'm not a historian. So for those of you in the audience who are truly historians, be kind, please. Trauma is a word that means wound in Greek, and is often the result of an overwhelming amount of stress that exceeds one's ability to cope, or even one's ability to integrate the experience. We know that trauma is a subjective experience because people react to events differently, similar events differently. From a psychological standpoint, trauma represents a deep, distressing, or disturbing experience. From a medical point, it still is defined as a physical injury. Trauma can change the way that we make sense of the world. And it also changes sometimes how we see importance in our lives. I had a student who returned from a tour in Afghanistan who was diagnosed with post-traumatic stress. And he said to me, this trauma that I have has changed my view of the world. Herodotus, who was a Greek historian, 15th century, sometimes referred to as a father of history, and how he documented major events in the war between the Greeks and the Persians. In the first conflict in Marathon, he wrote this: "A warrior went blind when he witnessed a fellow soldier killed, although the soldier who went blind was wounded in no part of his body." In the famous Iliad by Homer, there's a reference to Ajax, who, after many, many battles, loses a duel. And it's said that he came under a spell from Athena, and he began to slaughter a herd of sheep, thinking that they were the enemy. And then he killed himself. Johannes Holford, in the year of 1678, he was a Swiss physician, and he wrote a paper on a mysterious illness that he was trying to understand. He wrote a paper about these soldiers that were coming back, Swiss soldiers that were coming back from foreign campaigns, but seemed to have symptoms that had similarities with the soldiers that were coming back from various campaigns. He coined this term nostalgia. Nostalgia coming from the word nostos, which is returning home, and algia, which means pain. So he was describing these soldiers coming back from these campaigns that seemed to be returning home, but all seemed to be in much pain. The symptoms that he noted were melancholy, incessant thinking of home, a deep disturbed sleep or insomnia, loss of appetite, high levels of anxiety, and cardiac palpitations, or we would have known as tachycardia today. This was the first time in history that this notion of trauma, something that was happening with these individuals, was actually given a name. During the era of Napoleon, who was the Emperor of France from 1804 to 1815, who fought 60 battles with his armies, only losing 7 of them towards the end after a disastrous invasion of Russia, and then finally defeated in 1815 at Waterloo. His chief surgeon noticed this notion of nostalgia and saw the same kind of symptoms in the soldiers that fought these battles. He tried to prescribe some kind of treatment that might be relevant, that might be helpful. What he did prescribe and thought would be helpful for these soldiers was to prescribe regular exercise, listening to music, and useful instruction. It probably sounds more like a day at the spa, if you look at that. But at least some attempt was made to try to rectify and to try to treat some of the symptoms that were noted in these soldiers. Dr. Jacob Mendez da Costa, who served as a physician at probably the first military hospital, I believe that was in Washington, D.C., as well as the Turner Hospital in Philadelphia, was trying to gather evidence as to why some of the soldiers were exhibiting some of the symptoms they were exhibiting coming back from war. He noticed that the soldiers again had similarities in the symptoms prior: chest thumping or tachycardia, high levels of anxiety, and breathlessness or being hyperarousal. He studied actually 300 soldiers with these symptoms, and he came up with calling these symptoms soldier's heart, because he believed that the nerves at the base of the heart were somehow affected by the trauma that they experienced. We should note, too, that during the Civil War, there were some technological advances that actually had negatively affected the soldiers at hand. For example, prior to the war, bullets that were round were shot from guns. But during the war, the bullet's shape had changed, and the shape was more of a cylinder. Now, round bullets, when they hit a person and strike a bone, usually creates a clean-cut break. Cylinder-shaped bullets, when they hit a bone, they shatter the bone, which may have accounted for the many amputations that we heard about and read about during the Civil War. So soldiers were definitely were exposed to more carnage at this war than in any other war noted. So military physicians were really at a loss to how to treat this notion of soldier's heart. Many, many soldiers were put on trains with their names and their hometown pinned to their tunics. Many were just left to wander the countryside until they died, either from exposure or starvation. In 1863, the first military hospital was established, and the primary diagnosis at that time in the hospital, and the majority of the diagnoses in the hospital, was this notion of nostalgia. Nostalgia was also referred to as neurasthenia, which by definition simply means a state of physical or mental exhaustion. So after the Civil War, we were as a society becoming more aware of this notion of trauma. As railroad travel became more common in the late 19th century, so did many, many railroad accidents. Victims of these accidents were referred to as having railway spine, or as if their spinal cords had suffered a concussion that caused them to be more nervous or traumatized. Charles Dickens wrote about this after experiencing a railway accident himself. He wrote about being curiously weak, as if he was recovering from a long illness. The accident that he was involved with actually involved the train plunging off of a bridge where 10 people had actually died and 49 people were injured. In a letter that Charles Dickens wrote to a dear friend, he wrote this: "I begin to feel it more in my head. I sleep well, I eat well, but I write a half a dozen notes and then I turn faint and I get sick. I'm getting right, though still low in pulse, and I'm still very, very nervous." He also wrote about how after the accident that he experienced, he was unable to even stand on a train that wasn't even moving, because he felt that every time he got approached a train and stepped on the train, he felt that he was somehow feeling as if his body was tilting and he couldn't keep his balance. Interesting enough that Charles Dickens died on the 5th anniversary of the train crash that he experienced. Some believe during this time with the notion of railway spine, some believe that the symptoms were just wanting the people who had, the victims of the people who had suffered from this railway spine, were simply wanting compensation from insurance companies and railroads to have some compensation made for their injury. They were also called, this was also called during the time, compensation neurosis. Interesting to note that the people that did experience traumatic kinds of experiences due to these accidents, most of them were sitting with their back towards the front of the train, meaning that their back was towards the acceleration of the train. And we can kind of look at this now and see the similarity between what they experience and what we call whiplash today. During the war between the Russian Empire and the Empire of Japan in 1904, and this was a war that Russia was looking for a warm water port in the Pacific for the Navy, for their Navy, as well as their maritime trade. The Russian army during this war, they had lost the war, but during the war, they were the first army in history to really determine that a mental collapse was a direct consequence of the stress of war and should be regarded as a legitimate medical condition. This changed military psychiatry. This was some considered to be the birth of military psychiatry, where we were looking at the psychological condition of the soldier versus his physical condition. They also implemented during this war this proximity or forward treatment, meaning the fact that the soldiers would be treated near the front and treated as effectively as they can. And then after treatment was given, or the soldier was released, he was released back into the battlefield. Although armies today believe that the Russians were right in treating these psychiatric casualties close to the front with the goal of returning the soldiers to battle, their method proved to be unsuccessful. less than 20% were able to return to the battle. So April 16th, 1917, the U.S. joined its allies, the British, the French, and the Russians, into World War I. During this war, almost 2 million American men were sent overseas to fight. The deaths, over 116,000. Wounded, over 204,000. Affected psychologically and removed from combat, over 159,000. And nearly half of them, 70,000, were permanently discharged. The term shell shock came out, and this was coined by a British physician, Charles Myers, to describe symptoms of mental trauma that soldiers began to display. It's an incredible photograph, isn't it? This was a new style of warfare, referred to as trench warfare. Soldiers were involved in month-long battles, large numbers of casualties, sometimes fighting for days next to the bodies that lied next to you. Limited living space, and the effects on mental health of soldiers was overwhelming. There was a constant barrage of artillery, not to mention the toxic gas that they were exposed to. This notion of shell shock was thought to be caused by a concussion that disrupted the physiology of the brain. Thus came this name, shell shock. Some of the symptoms that were seen to be consistent with the soldiers that were experiencing this shell shock: the staring eyes, violent tremors, extremities that were cold, sometimes even turning blue, and even unexplained deafness, blindness, or even paralysis. Many of the British and Australian psychiatrists attributed the suffering not to the conditions of warfare, but rather the individual having a weak constitution or even lack of character. Soldiers were accused of being cowards, even weak, which that was the contributing factor that led to this notion of shell shock, not the war itself. Self-injury in soldiers was high. 3,000 cases of desertion in the British Army alone, and over 309 to be exact, soldiers were court-martialed and sentenced to the death sentence because they thought that they were weak and cowards. This is an early film, short film, that just shows some of the symptoms of this notion that we call shell shock.
Others proved unable to overcome the psychological impact of war after living in these trenches full of mud, dirt, and dead bodies. The form of trauma known as shell shock was very common among war veterans, and it caused its sufferers to undergo fits of intense fear and shaking. The fear of being bombed, which they had lived with every day for 4 years on end, was engraved in their brains. Some patients felt compelled to go hide themselves at the mere mention of the word bomb. Some veterans even felt terror grip them whenever they saw a uniform. Tens of thousands of soldiers also lost one or more limbs in this war.
So in treating this symptom of shell shock, in 1917, U.S. Army Surgeon General's office created what they considered to be a comprehensive treatment for those soldiers showing signs of shell shock. One of the things that they did was to start placing psychiatrists in combat units. And the treatment was centered on something which was referred to as proximity. Proximity meaning immediacy, treating the soldier as close to the battle as possible. Simplicity, providing simple treatments such as rest, a warm shower, and food. And then expectancy, the expectation that the soldier will return to fight after he has been treated. Many of the soldiers that were removed from the battlefronts were actually referred to as having an acute anxiety disorder, which usually implies acute meaning short term. And much of the soldiers that were given that diagnosis with the notion of acute, meaning the fact that we will treat them, but the expectation is they will go back into battle. But we now understand that psychologically traumatic events that is really outside the range of normal human experience can have long-term effects, both physical and emotional. So the experience of this notion of shell shock became a major influence in the development of psychiatry, in particular military psychiatry. We were forced to kind of realize that an otherwise normal person would break down under a significant amount of stress. So World War I served as a catalyst, consolidating the acceptance of pure psychological causes for mental symptoms. Again, the biggest problem during this time was the belief that this was an acute illness, not a chronic illness. After the war in Vienna, many soldiers were reporting that they had been mistreated by doctors and felt that they were suffering from what they termed to be war neurosis. During this time in Vienna, Sigmund Freud was around, and he was even asked by the Australian War Ministry to kind of see what he thought was going on with these individuals. Well, if you know anything about Freud, he would never lose an opportunity to kind of talk about what he thought was important, and he did. And he brought up this notion of war neurosis. Freud, if you studied Freud, much of what he talks about in terms of conflict meaning internal conflicts, and how people suffer from these internal conflicts would create a mental disorder, and how to treat mental disorders is to somehow find resolution to these internal conflicts. This was no exception when he talked about war neurosis. He talked about the old eagle of peace, in which he referred to that these soldiers, before they went to war, had what he referred to as a peacetime ego. And when they returned from war, a new ego had developed, the war ego. And the anxiety that they were suffering, he felt, was an outcome of this. The peace ego was being fearful of having to face the danger of someday being killed by the war ego. He talks about how ego protects itself by taking flight. It's one of Freud's common descriptions when he talks about ego and mental illness. But he was on to something, I think, at this point. When he talks about the old ego protecting itself and taking flight, it's almost as if he's describing this state of dissociation. And we see this with people suffering with PTSD, the ability to dissociate, to remove themselves from the reality of what they're experiencing. In World War II, just some interesting statistics showing these psychological casualties as well. In the 4 years of war, approximately 800,000 soldiers saw direct combat. And of these, about 37.5% became serious psychiatric cases and were permanently discharged. In the U.S. Army alone, not counting the Army air crews, over 500,000 men were removed from combat for psychiatric reasons. And another almost 4 million suffered debilitating symptoms. So we have new names for the same symptoms. During World War II, we had called these soldiers that were suffering and showing these symptoms, having traumatic war neurosis, combat fatigue, sometimes referred to as battle fatigue, battle stress, and gross stress reactions. It became clear that it was not just the weak in character who were breaking down to combat. But the Army, at this point, still wanted to maintain a model of predisposition, meaning the fact that they felt that a person's character was affected. If a person was of weak character and undergoing the stress of war, this would cause these symptoms. So we still wanted to hang on the notion that it was about the individual. It was not about primarily the experience. It had something to do with the person that would show these kind of symptoms. During World War II, we also employed this notion of forward treatment, meaning going out into the battlefield, treating individuals with the expectation that they will return back to the battle. One of the things that we did learn, though, during World War II that seemed to provide and made a difference in the soldiers' resilience to the stressors that they were having was their sense of cohesion with the people that they fought next to, the people that they fought with. If there was a sense of cohesion and a sense of support, that seemed to be a factor in a person's ability to deal with these stressors more effectively. So this whole notion of trauma and stress and how it affects us not only psychologically, but how it even could affect us physically, was starting to become more and more common in how the general public was starting to understand this notion of trauma. An example of this is back in 1942 in Boston, Massachusetts, the nightclub, the Coconut Grove, which was a very popular nightclub during the time, caught fire. 400 people perished during that fire. 350 people were injured. And we started to see the response of the people that were pulling the bodies out of this burnt building and starting to kind of find out that they were having effects of stress. They were having these effects of psychological trauma just by what they experienced. So it started to bring more awareness of how extreme stress reactions affected the victims. We know this even with 9/11. It made us think differently about the effects of stress. And now in the war in Iraq and Afghanistan, this notion of induced stress, or PTSD, as I'll be talking about here in a minute, is very, very much in the public eye. During this time also, because of the notion of the awareness of people becoming more aware of how stress was affecting us, Dr. Hans Sella, who was a Hungarian biochemist at the time, was doing much research about stress. Matter of fact, he is kind of noted as the doctor who actually coined the term stress. He's the one who kind of put together what we now call this general adaptation syndrome, which basically, in reality, is that fight or flight, how our bodies react, and how our bodies react to stress, and how the biochemical changes can occur when we're highly exposed to stress. He basically talked about how Prolonged and repeated exposure to a stressor will have serious implications, not only to our emotional health, but will affect our physical health as well. Interesting thing, just a little side note about this notion of stress and the word stress. Dr. Sella, who again was Hungarian, he spoke about 3 or 4 different languages, spoke English but didn't speak English well. And evidently the story goes it was very difficult to understand him when he spoke. And he says, after this notion of how we adopted this word stress, he says an interesting thing was, that's not what I said. What I said was strain, not stress. But stress became a word that people hung on to and they started to use. So Dr. Sella said, good enough, we'll call it stress. So with this awareness that we have in the public about learning about how stress can affect us, both psychologically and physiologically, back in 1952, the American Psychiatric Association developed a manual. The manual was called the Diagnostic and Statistical Manual for Mental Disorders. This is the Bible, so to speak, if you want to call that, in how we diagnose mental disorders. This is the book that we refer to, and we look at symptoms, and we see if symptoms are in line. If the symptoms do show for a certain amount of duration of time, then we can actually give a diagnosis, and this is the book that does this. This started back in 1952, and because of the awareness of this notion of stress, they included a category called gross stress disorder. It was given to define a stress syndrome that was a response to an exceptional physical and mental stress, such as natural catastrophe or battle. But there was still a lot of discrepancy. There were many, many people in the medical profession that still felt that stress was not a mental illness. It should not be included in the DSM. This is something that we don't have enough evidence to kind of validate this as a mental illness or an effect of a mental illness. So back in 1968, when the DSM, which we abbreviate here, DSM-2 was published, and the diagnosis of gross stress disorder was omitted. They took it out. Now, during this time, if you remember, the Vietnam War was going on, and this was a war that was not popular. And we were starting to see many, many soldiers coming back from Vietnam, and it almost reminded us of what had happened during the Civil War. People that were coming back and not being able to maintain a job, and being homeless, and substance abuse, and just wandering. And because of the unpopularity of the war, and so much was happening with the soldiers returning, activists began to note that there needed to be some kind of treatment for these soldiers that were returning back. We needed to do something for them. So back in the mid-70s, we were starting to reveal more and more and learn more and more about stress. And so back in 1980, when the DSM-3 was developed, the category of post-traumatic stress was finally included. Since then, there have been many revisions of the DSM. Back in 1987, with the DSM-3R, R meaning revised, many modifications that address stress were now being included. And more interest in clinicians and how to treat these stress disorders, and more emphasis was finally being given to the psychological nature of stress, as well as the physical components that it may entail. And the most recent addition here is the DSM-5, which was released last year. So what is PTSD? What is post-traumatic stress? These are some of the signs and symptoms that we see with individuals that are suffering from this. Efforts to avoid thoughts, avoiding activities, poor memory, anhedonia, which basically means a lack of pleasure, or finding lack of pleasure in your life. Feeling detached, Feeling flat. We notice a lot of these individuals lack facial expressions. They're almost, as we would refer to as their affect being flat. A sense of foreshortened future. These individuals don't see their lives in long terms. They see themselves, their lives in short years. Flashbacks, difficulty with sleep, irritability, outburst of anger, hypervigilance, always on guard, always kind of being suspicious of what may be around you and what's going on. Difficulty concentrating, exaggerated startle response, and intrusive thoughts. In some cases, PTSD symptoms may not appear until years later, or even years later after the event. And usually now we look at PTSD and we usually try to categorize it in three kinds of different groups. One that has more intrusive memories, one that shows more symptoms of avoidance or even numbing, and another with showing high levels of anxiety. Some of the implications of PTSD, these individuals have a greater risk of developing other disorders. 80% of the people with PTSD do develop another kind of diagnosis. Many of them suffer from depression. Many of them have substance abuse disorders or substance abuse problems. And many of them, or I should say most of them, show levels of higher anxiety as well. Difficulty keeping a job is another symptom that we see with these individuals that suffer from this. Relationships suffer. Health problems. Anger and violence. So generally they have a worse quality of life. These individuals and families and relationships struggle. Most people who suffer from PTSD want to kind of avoid any kind of social situations. They suffer from nightmares, sometimes night terrors. Depression is common, and lots of anger, but more important, lots of guilt. What's the guilt about? The guilt may be feeling not able to provide for their family, not being able to control their own emotions, not being able to control themselves in ways that they once knew. Also, we see health problems as well with victims of PTSD. They develop habits sometimes that they've not had before. Drinking, smoking, drugs. They show sometimes a lack of wanting to exercise. And they become kind of lethargic in their lives. They're kind of wandering and wondering what they can do. So some of the treatment of these individuals we found to be helpful, although we're still learning more and more about it. One of the major kinds of psychotherapy that we use with individuals that are suffering from PTSD is this model that's called cognitive behavioral therapy. This is a kind of therapy that basically its goal is to understand how certain thoughts, have your client understand how certain thoughts about the trauma that they experience are causing the stress and that's causing their lives to be worse than what it was. These clients learn through the help of their therapist, learn to replace these kinds of damaging thoughts with a more accurate and less distracting thought. So the notion is this, and it's kind of a simple idea, but it's effective. If you can get someone to acknowledge what they're thinking and how that thinking is affecting their behavior, if I can somehow modify the thinking and change that level of thinking, then the behavior should change as well. And this is what we teach in cognitive behavior therapy. We teach our clients to be aware of what's going on inside and to start making adjustments in how they're thinking. Another treatment that we use for these individuals, obviously we use medication. and that could be effective in conjunction with psychotherapy. The problem with medication, like most medication, in particular psychotropic medication, is the fact that we take psychotropic medication for long periods of time, then we start to develop a tolerance of that. And then we have to go back and find out if our dose has to be adjusted, or do we need to kind of even pursue a different kind of medication. Medication like psychotropic medication, like any medication, does have high degrees of side effects. Many psychotropic medication affects an appetite. It can either lower your appetite or increase your appetite. This is why a lot of people on this kind of medication gain weight. It can create a state of dizziness, a state of sometimes feeling like you just want to sleep all the time. So there are some major side effects with the psychotropic medication. We found also with people who suffer from PTSD that family therapy is important. Why? Because it affects their relationships. People who suffer and come back from the war with PTSD and go back into their family, what we are noticing now is the family itself in time will develop PTSD, only because of the effects of the trauma and the influence that a person had on the family. Again, if a person comes back that had some normalcy in their life and had some interaction with family and now comes back and here's a person who is withdrawing, maybe having nightmares, not able to sleep, anxious all the time, not being able to have a relationship, both emotional or even sexual, it changes the family dynamics. And what we see with these families, they're showing symptoms now of PTSD as well. So family therapy, we're finally realizing, is crucial in the treatment of individuals that come back that have this illness. And one of the interesting things that we're finding that's part of the therapy is this notion of virtual reality therapy. Virtual reality therapy, or sometimes referred to as exposure therapy, is, as you see in the picture here, here's a soldier who has a virtual reality headgear on with the headphones. And what he's seen is actually a recreation of the place that he had been, whether it be Afghanistan, Iraq, whatever the case may be, and they are able to recreate the conditions and the area in which this person may have described as being part of that traumatic experience. The notion is confronting the trauma, confronting what was that memory that seems to hold you down, and re-experience it in such a way in which the re-experiencing is in a safe environment and a very controlled environment. It's kind of like desensitizing, getting a person to kind of face his demon, look at it, learn now at this point it cannot harm you, and learning to become desensitized and recreating and reliving the incident. We found this to be very, very effective and found it to be more effective than we even had ever realized. But the interesting thing about this is that the effects of this kind of treatment seems to be more predominant and more effective with young soldiers. Why? Because they grew up in this digital technology. This is something very, very familiar to them. This is something that they know how to operate. This is something that they know that is part of kind of their upbringing. So they become very, very comfortable with it and tend to be very effective. It tends to be very effective and very helpful for them. So I'd like to show you a video now of a young soldier who is suffering from PTSD. His name is Staff Sergeant Billy Cavanis. He's a 4-tour veteran of Afghanistan, a 16-year veteran of the Army. And he talks about his experience, what it's like to live with PTSD.
I'm always worried about somebody coming in my house and hurting my family, but I'm always on guard, and I'm ready for anything at any time. I used to be able to determine combat zone and home, but now to me, everything's combat zone. And that's because of the PTSD. If you got it, you'll understand exactly what I'm saying. I joined the Army in May of '96. I've been in 16 years come May, and I've been on 4 deployments. Well, the camp that I was at is called Combat Outpost Tonic Miracle. We were down in the Garnhall Valley, surrounded by mountains, and over to the left-hand side of us where I was, my motor pool was at, was Pakistan. And every day was a fight for survival. You just didn't know when it was coming, but you knew it was coming. 1st of May, I got a briefing around 11:30 on what was going to happen that following morning. I came back, briefed my soldiers, prepared for battle. Our main objective was to man the front gate. Anybody come through that front gate, they were dead. All of a sudden, we hear one whistle. First round lands on the left-hand side of us. It knocks me and all my guys on our backs. We jump up. The second round came in, hit one of the fuel tanks on the 22-ton crane. The last mortar round, an RPG recoilless round, landed 6 to 8 feet in front of me and my guys. It blew me down first, and then 5 to 6 of my guys got hurt, and 2 of them seriously wounded, and one of them being me and PFC Ricks. He almost died. My injuries, I got wounded in the penis and my right thigh. I took, can't give you an exact number of shrapnel. You know, that's my manhood. When I first came to in the infirmary out in Cobb Honaker in the Apache Valley, I just couldn't believe it. I was hysterical, just in shock. And me and my wife were always thinking about having a 3rd kid, so that's a no-go. It's over. There's a lot of things that come along with severe PTSD. Sleepwalking. Can't sleep for days at a time. When you do sleep, you only sleep for an hour or 2, and you're right back up for 3 or 4 days. Hallucinations, constantly thinking about the situation what was at hand that puts you in the situation you are in now. Thinking about and seeing the faces of the soldiers that either passed on or got hurt severely. That's an everyday struggle for me. That's our captain, San Antonio, Texas, been in 16 years. Me and my guys got hit by 4 mortars that are recorded as RPG round. 11 pieces of shrapnel on the, that's what you said. That was a really big help to be around other vets and soldiers that have been into similar circumstances, like getting wounded or getting blown up and getting hurt real bad. We all could relate, and from the day that I walked in there until the day that I walked out and graduated, let me tell you something, that makes a really big difference for somebody just to understand. You know what I mean? What, 305, 350s?
Yeah, there's like 2 or 3 people called.
Treatment, being around those guys that have been through similar situations, it's one of the best things ever. I used to blame myself all the time for them soldiers getting hurt and almost coming to death. But I also got to realize I was the first one to get hit, and I also got to understand and tell myself that it wasn't my fault, because I did everything I could to keep my soldiers safe, and I was the first one to get blown down. So that's another part that keeps me going. I think that helps me move along sometimes.
Don't you love happy endings? So in conclusion, regardless what we call it, trauma has always and likely always will be, an aspect of what we call the human condition. Trauma cannot be transcended. It's inherent in our primitive biology. The only way we will be able to release ourselves individually and even globally is to learn to transform the effects it leaves with us. A better understanding of the interplay between the physical and the psychological components of trauma definitely needs more study. There are still many questions that need to be resolved. How the mind and body connect, the complex interaction between the severity and duration of a stressor on an individual, the ability to effectively use coping skills which are aligned with the person's experience of the trauma. Throughout history, men and women have acted to suppress the horrors that they have seen. It's time we recognize that for what it is, as not only the outward manifestation of trauma, PTSD, stress, whatever you may want to call it, but the clearest evidence that we have that wars are destructive in other ways other than simply body counts. Viktor Frankl, a psychiatrist during the Second World War, a psychiatrist who was a survivor of 4 Nazi concentration camps, camps that not only took him but his wife and his parents who had perished. Later wrote a book called The Man's Search for Meaning. He said this in a very simple quote, but very effective. An abnormal response to an abnormal situation is normal behavior. In other words, as a student once told me in a discussion about this, if some things don't make you crazy, then you aren't sane to begin with. Thank you.